It is 3 a.m. in the intensive care unit. The alarms are blaring, nurses are moving rapidly between rooms, and right in the middle of it stands a resident physician entering their 72nd consecutive hour without sleep. American medical culture has historically treated these multi-day continuous shifts as a normal operational standard. Trainees are taught that sleep deprivation is a professional rite of passage, a test of dedication that ignores the evolved limits of human physiology. Sleep is a highly active, metabolically demanding event. It provides a process called synaptic homeostasis, which is how the brain resets its neural connections while physically flushing out toxic waste products that build up during the day. Denying the body this non-negotiable clearance cycle for 3 days pushes the brain's highest-order networks toward a cascading failure. The damage starts directly behind the forehead, inside the prefrontal cortex. This is the neural engine responsible for executive attention, strategic planning, and complex medical decision-making. Mapping global brain glucose metabolism reveals the exact cost. After 72 hours, fuel supply plummets by 15% within the prefrontal cortex. This metabolic starvation physically severs the neural pathway connecting the prefrontal cortex to the amygdala, the brain's threat detection center. Stripped of that logical, top-down control, raw emotional reactivity amplifies by 60%. The amygdala becomes hyper-reactive, generating sudden aggression, deep paranoia, and a neurological profile that mirrors severe psychiatric mood disturbances. Without logical governance or emotional regulation, the resident operates with a frontal lobe that has functionally decoupled from the brain's internal monitoring systems. Between 24 and 48 hours awake, the brain begins aggressively defending itself against cellular damage. It forces localized neural networks entirely offline, creating involuntary microsleeps, where the individual temporarily loses all connection to their environment. This bar chart directly maps the cognitive decline induced by sleep loss against standardized blood alcohol concentration benchmarks. Reaching 24 hours of wakefulness degrades executive function to a level equivalent to a BAC of 0.10%. That exceeds the federal limit for operating a motor vehicle in the United States. Sleep deprivation produces a unique camouflage. A resident can walk in a straight line down a hospital corridor, even as their internal reaction times drop by 50%. As the clock nears 72 hours, the thalamus, the brain's sensory relay station, begins to degrade. This misrouting of sensory information triggers sensory processing failures, complex visual hallucinations, and acute paranoia. For decades, the American healthcare infrastructure has routinely placed critical patient care in the hands of individuals functioning in a state legally identical to severe intoxication and acute psychosis. If biological science shows this practice is mathematically disastrous, why did it become the bedrock of the U.S. medical residency? The answer traces back to the late 19th century. William Halsted designed the modern, unlimited-hour pyramidal residency model at Johns Hopkins Hospital, establishing the system of indefinite, multi-day shifts that shaped generations of physicians. Halsted didn't build this grueling schedule to maximize educational excellence. He designed it to accommodate and conceal his severe, lifelong addiction to cocaine and morphine. As his addiction deteriorated his cognitive stamina, Halsted relied on a legion of brilliant subordinates. By demanding they live in the hospital and work unbroken multi-day shifts, he could limit interactions with his peers and hide his impairment while the residents managed the hospital's clinical workload. A structure designed to mask a founding surgeon's narcotic addiction was quietly absorbed into medical culture. The grueling 100-hour workweek was rebranded into a moral rite of passage, entirely divorced from the reality of human biology. In 1984, the consequences of that history became impossible to ignore. An 18-year-old patient named Libby Zion died from a fatal medication error, under the care of unsupervised, sleep-deprived residents on a 36-hour shift, finally indicting the Halstedian system. Modern epidemiological data reveals the actual cost to patient safety. Traditional extended shifts drive a 35.9% increase in serious medical errors. The collapse is most pronounced in diagnostic reasoning. Starved of glucose, sleep-deprived interns commit 5.6 times as many serious diagnostic errors. This system is equally lethal to practitioners. Chronic sleep deprivation triples the risk of Sharp's injuries. Furthermore, the biological strain of a 72-hour shift has repeatedly triggered fatal neuroelectrical seizures in otherwise healthy young medical workers. Modern regulatory bodies have attempted to cap these shift lengths to solve the problem, but breaking up shifts means patients are transferred between doctors much more frequently, introducing a new hazard where critical clinical information is lost or misunderstood during handoffs. Medicine remains caught in a debate between the danger of fatigue and the danger of informational decay. But the biological boundary remains. No amount of professional prestige or administrative scheduling can bypass human evolutionary limits. Pushing a physician past 72 hours guarantees catastrophic failure.